Good afternoon, folks. We'll get started in just a minute.
Okay, it's
I
popping up.
can hear you and see you now.
Okay, and it's the PowerPoint up for her?
Yeah,
Okay,
I'm good on my end.
okay, great. All right. She's coming now.
Thank you.
Okay.
Good afternoon, Dr. Ferrer.
Hi, Kim. We should just get started.
All right. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health today, July 14th, for a media briefing. Today we have the Director of Public Health, Dr. Barbara Ferrer, presenting. Dr. Ferrer will then take your questions. As a reminder, as always, please use the hand icon or you may chat me, the host. Dr. Ferrer, when you're ready.
Thank you and good afternoon. Thanks so much for joining today's briefing. I'll give a COVID-19 status update for LA County, and we'll also discuss the universal indoor masking requirement we are likely to need in the coming weeks. I'll take the first slide. Do you have that, Kim?
I have it up. Can you see it?
I can't. There it is. Okay, perfect. Cases, hospitalizations, and test positivity remain elevated. Today, we're reporting 8,535 new cases. That brings the average number of cases reported this past week to above 6,400 new cases per day. As a reminder, all case numbers are an undercount since they don't include positive results from the over-the-counter tests. The daily test positivity rate is averaging slightly over 16% this week. And as you can see, it's been increasing. This reflects the increasing rate of transmission associated with the highly new infectious COVID subvariants. Statewide, the positivity rate is also at about 16%. Nationwide, it's just under 18%. Many healthcare providers in the community are telling us that they're seeing closer to a 40% test positivity rate amongst their patients coming in for care. We're also experiencing continued increases in the number of COVID positive hospitalized patients over the past week, from 989 last Thursday to 1,202 today. Among those hospitalized who are infected with COVID, about 42% are hospitalized with COVID-related illness. This rate has remained relatively stable this past month. Sadly, we're starting to see increases in deaths for the first time since the winter surge, with an average of 14 deaths reported per day over the past week. An increasing proportion of these deaths are associated with outbreaks in nursing homes, and the death rate from COVID surpasses that for many other health threats in our county. And I'll talk about both of these metrics later in the presentation. For those who have lost a loved one to COVID, please know you remain in our thoughts and our prayers, and we're wishing you peace during these very difficult times. Next slide. If we look at the trend lines for the past year for daily cases, that's the green line. We can go to the next slide. Kim,
Yes, Dr. Frere?
can you go to the next slide?
Was the second slide not correct? This is the second slide I have.
Yeah, it didn't show up. So I'm not sure. There seems to be a problem with the slides, so.
I think there's a lag today. I apologize.
Okay. If you see this trend line for the past year for daily cases, that's the green. No, we'll go back to the last slide. Thank you. For daily cases, this is the green line. Hospital admissions, that's the orange line, and deaths in the blue line. You can see clearly that our current surge looks somewhat similar to the Delta-fueled surge that we experienced last summer, where daily cases peaked at about 3,500 and daily new hospital admissions peaked at 215. Can you advance the slides to the next slide, please? With the
I apologize, Dr. Frere. I think there's a delay. You want the 7-day
I just want,
daily.
no, I wanted to stay at this slide with the trend lines.
Okay.
Does that work?
Yes.
And as many remember, with the surge in cases last summer on July 17th, 2021, universal indoor masking went into effect for everyone age 2 and older in LA County as a protective measure. While we're not seeing anywhere near the devastation this summer that we saw during last winter's Omicron surge, we are seeing much higher case numbers than we saw during the peak of the Delta surge. It's unlikely that we're at the peak of this recent surge, given the increased circulation of new subvariants of concern. And we already have an average of over 6,400 cases being reported per day. And while thankfully our average number of hospital admissions, which is currently at 157 per day, has not yet risen to the peak level of 215 per day that was seen in the Delta surge, with increasing hospitalizations, it is possible that we'll see similar numbers in the weeks to come. As I noted earlier, although many of those hospitalized are not there because of COVID illness, the rising numbers do indicate that for significant numbers of people, COVID remains a very dangerous virus. We'll go on to the next slide. We do continue to track the impact of the pandemic on LA County using the CDC's COVID-19 community levels framework, which is a measure of the strain on our healthcare system caused by COVID-19. The community levels framework utilizes one case rate metric and two hospitalization metrics. As of today, we have moved from the medium to the high COVID community level. The first metric is our 7-day case rate, which is currently at 370 cases per week per 100,000 people. The first of the two hospital metrics is the 7-day total of new hospital admissions per 100,000. Using LA County specific data, we're at 10.5 admissions per 100,000 people. This is an 88% increase compared to 1 month ago. Since this metric has moved above 10 per week per 100,000 people, we have moved into the high community level. The second hospital metric in the CDC community levels framework is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. Currently, 5.4% of beds are occupied by COVID patients in LA County. This is an increase of 84% compared to 1 month ago. As I've mentioned in past briefings, if we remain in the high COVID-19 community level for 2 consecutive weeks, that would be through July 28th, we would implement universal indoor masking on July 29th to help slow the rate of transmission and protect those most vulnerable. And I'll talk more about this in a few minutes. Next slide. Our early alert signals also continue to indicate increased risk across the county, associated with the proliferation of highly transmissible variants. This is having a particularly concerning impact at work sites and among residents in our nursing homes. As you can see on this table, 4 of the 7 early alert metrics that we're tracking convey cause for high concern. This includes the percent of new variants of concern, the case rate in areas with higher poverty, the number of outbreaks at skilled nursing facilities, and the number of clusters at work sites. 2 early alerts conveyed medium concern. This includes the percentage of emergency department encounters that are COVID-related and the number of outbreaks in settings serving people experiencing homelessness. And while we aren't reporting any wastewater systems that have experienced a twofold increase in viral load over the last 14 days, we are missing data this week from 2 of the largest systems. So this data is incomplete. I'll review a few of these metrics over the next slides. Next slide. The Omicron variant continues to account for 100% of the sequence specimens. However, the proportions of subvariants of Omicron continue to shift. The greatest concern remains a steady increase in the proportions of BA.4 and BA.5 subvariants. That's shown by the red sections at the top of each bar on the right. In the week that ended June 25th, so I want to note this is a 2-week lag, BA.4 and BA.5 accounted for 62% of all specimens sequenced, which is over double the proportion just 2 weeks prior. BA.5, as you can see, is dominating as it comprises 48% of all of our sequenced specimens. The CDC is estimating that across the country, as of the week that ended July 9th, the BA.4 and BA.5 subvariants of Omicron combined accounted for just over 81% of specimens. Again, a considerable increase from from 53% that we saw 2 weeks earlier. In both the national data and the LA County data, BA.4 and BA.5 continue to outcompete the BA.2 subvariant and its sublineages. As you can see, the BA.5 subvariant is increasing at a faster rate than BA.4. Both BA.4 and BA.5 are of special concern because of their ability to evade prior immunity and therefore reinfect people who were infected with other Omicron subvariants as well as other variants. It's highly likely that the increased circulation, particularly of BA.5, will contribute to increased risk for infection among many in our community. Moreover, a few days ago, the WHO highlighted the concern with the spread of a new sublineage of the BA.2 Omicron subvariant. It's called BA.2.75, and it's considered a lineage under monitoring by the WHO. It does appear to have additional mutations that facilitate spread and evade immunity, and it's been spreading fairly rapidly across India. 6 cases have been identified so far in the USA. 2 of those are in California, and 1 of those cases is from LA County. Whenever there's an identified new variant of concern, or in this case, a lineage that's under monitoring, we do need to proceed with caution as it takes time to better understand the risks that may be posed by this newly mutated virus. It takes time to determine with certainty the ability of a newly mutated virus to evade immunity protections, to easily infect others, and to cause severe illness. Until we have a sense of how the virus is interacting with us with these new variants, using sensible precautions remains a very good idea. Next slide. With more cases, our emergency departments and urgent care centers are increasingly seeing individuals needing medical attention for COVID. As you can see on this slide, or you'll be able to see in a minute, the blue line shows the 7-day rolling average percentage of emergency department encounters which were COVID related between March 1st and July 10th of this year. I need the next slide. Yeah, thanks. The proportion of ED cases that have involved people seeking care for COVID, as you can see, has been steadily increasing, and now it's just below the threshold for passing into high concern. This signals that COVID is placing increasing pressure on our medical systems as viral transmission increases, and there are many more infected people that are sick enough to seek emergency medical care. Next slide. In the next 2 slides, I'm just going to share the latest SARS-CoV-2 wastewater concentration data from the 2 sewer systems that are currently reporting data. The other 2 sewer shed testing programs, and those are our larger programs, experienced a delay in testing and reporting because of a supply chain shortage on testing supplies at the state level. But we do expect to be able to report out on their data next week. For the Las Virgenes Municipal Water District, which is what we're looking at here, this serves the city of Calabasas and the surrounding areas, you can see a steady increase in wastewater viral concentrations since the second week in June, although the viral load did not double compared to the average 14 days ago. If we go to the next slide, this graph is showing the wastewater viral concentration results from the Los Angeles County Sanitation District's wastewater treatment plant in Lancaster. Here we see a steeper increase that started in late June. While we have more to learn about wastewater monitoring, just making sure we're getting this slide. Here we go.
I have the Lancaster slide up, Dr. Freer. I think you have
Thank
just a slight delay.
Okay. While we have more to learn about wastewater monitoring, examining viral load in wastewater provides a promising way to supplement testing data and strengthen surveillance so we can better understand levels of community transmission. Next slide. Surging cases in the community is creating increased risk for the most vulnerable, who can least afford to get infected. The number of new outbreaks opened per week in skilled nursing facilities, as shown by the purple line, continues to remain of high concern. Although there have been some fluctuations in this metric over the past few weeks, we're now recording the highest number of new outbreaks in skilled nursing facilities since January of this year. That was during the Omicron surge, with 41 outbreaks opened in just the past week, and many of these outbreaks involving 15 or more cases. When cases surge in the community as they are now, those most vulnerable are often disproportionately affected. A recent worrisome finding is that we're now seeing an increased percentage of our overall deaths associated with skilled nursing facility outbreaks. Back in May, about 5% of all deaths occurred amongst nursing home residents. Sadly, this number rose to 12% in June. This rising risk among the most vulnerable is also reflected in the increased proportion of COVID deaths among those aged 80 and over. We went from 44% in May to 58% in June. Skilled nursing facilities continue to provide enhanced protections to residents and staff. However, one important strategy for reducing the number of infected nursing home residents is, in fact, to lower the rate of community transmission. Next slide. There's also been a steady increase in reports of worksite clusters since late April. As you can see from the pink line in this graph, worksite clusters have been of high concern for a few of the past 4 weeks. This past week, we received 371 new additional worksite cluster reports. That's about a 43% increase over the number of cluster reports that were reported just 1 month ago. Similar to experiences at nursing homes, rising clusters of COVID cases at work sites reflects the overall rise in cases across the county. Workplace clusters and outbreaks are disruptive and hazardous, particularly as many more outbreaks now involve 20 or more workers. Staff need to abruptly take time off to isolate and recover, leading to staffing shortages and interruptions in customary operations. Worksite outbreaks create worrisome risk for vulnerable employees, and they often contribute to additional spread of the virus across households and communities where our workers live. As a reminder, all work sites in LA County are required to report to public health if they have had 3 or more cases in the prior 2 weeks, because this can signal a potential outbreak, and our staff are available to help manage that. Next slide. There is a lot of misinformation circulating about COVID, including that at this point, it only causes mild illness. Unfortunately, as you can see from the slides I've already shared, this isn't true, and COVID is still one of the leading causes of death in LA County. As we all know, and as you can see on this table, COVID has caused thousands of deaths every year, and the number of deaths from COVID this year from the Omicron variant and its subvariants is still very high. It's already over 4,400, and it will clearly increase significantly before the end of the year. We've already seen more deaths from COVID these past 6 months than we have seen annually from any other infectious diseases. And it's over 3 times as many deaths from COVID as we saw on average during a pre-pandemic flu season. Annual COVID deaths are also significantly higher than annual deaths from drug overdoses and motor vehicle accidents. As a community, we implement many protective measures to reduce fatalities, especially motor vehicle fatalities, that everyone needs to follow. This includes traffic rules, car safety requirements, limitations on alcohol consumption for drivers, and mandatory use of seatbelts. Given the reality, as we can see on this table, that COVID still presents dangerous risks, I do think it remains appropriate to take sensible collective actions to reduce virus transmission. This is similar to the approach we take to prevent motor vehicle injuries and fatalities. Next slide. With the expanded toolkit at our disposal, sensible protections fall into two categories: strategies for reducing illness severity and death, and strategies for reducing spread. The two approaches are inherently interconnected, and both are essential for reducing disproportionality and protecting those most vulnerable. Since you don't get sick if you don't get infected, slowing the spread will always be an essential strategy for dealing with COVID. When transmission is high, many more people are exposed and get infected, creating more risk for everyone, but especially for those more vulnerable. Universal masking and widespread use of testing are effective tools for reducing viral transmission. Masks provide a physical barrier, and testing lets a person know their status so they can avoid infecting others. And while vaccines and therapeutics are not 100% effective, vaccinations, boosters, and therapeutics provide the most powerful protection we have against severe illness, hospitalization, and death. These measures not only offer protection for the individuals receiving the vaccine or treatment, but they also end up protecting others in the community, and they reduce stress on our healthcare system. Next slide. While all of us know many individuals, perhaps including ourselves, that are vaccinated and have become infected with COVID, it would be incorrect to assume that the vaccines are not working. Although vaccines do not prevent all transmission of COVID-19, they are, as you can see here, very effective at reducing the risk of developing severe disease and dying. We can see this when we compare the rates of cases, hospitalizations, and deaths in unvaccinated and vaccinated residents. On this particular slide, we use the term fully vaccinated to include those who completed their initial vaccination series and who may or may not have received their boosters. During the 30-day period ending June 28th of this year, unvaccinated residents were about 1.5 times more likely to get infected than fully vaccinated individuals. And while this difference isn't huge, it suggests that even with the more transmissible subvariants of Omicron spreading in LA County, vaccines are still providing some protection against infection. During the same time period, LA County residents who were unvaccinated were 4 times more likely to be hospitalized with COVID, and they were 7.5 times more likely to die from COVID than those who are vaccinated. Next slide. As we align efforts across the county to protect those most vulnerable during this surge, we continue to note the disproportionate impact of COVID among some communities, including those communities with high rates of poverty. These tables show hospitalization and death rates from COVID by vaccination status for 4 different community income levels. The rates cover a 90-day reporting period that ended in late June. As you can see, vaccines offer powerful protection against serious illness and disease, as fully vaccinated people across the board were hospitalized and died at much lower rates than unvaccinated people living in communities with a similar income level. However, vaccines are not an equalizer, and disparities persist among vaccinated individuals. Vaccinated people living in communities where 30 to 100% of households live in poverty are nearly 1.5 times more likely to be hospitalized and almost 2 times more likely to die than vaccinated individuals living in areas where less than 10% of households are living in poverty. Vaccinated individuals living in our poorest communities actually have higher rates of hospitalization than unvaccinated individuals living in the wealthiest communities. And unvaccinated individuals in communities with high poverty were about 10 times more likely to be hospitalized or die than those unvaccinated living in the wealthiest communities. Families with fewer resources are more likely to have more exposures at work, live in crowded conditions, and have 1 or more chronic health conditions compared to those with more resources. This places individuals at higher risk of suffering the severe effects from COVID. Since vaccination alone is not sufficient to erase the troubling inequities we see, Additional efforts are needed to protect those at greatest risk. Next slide. As we just saw, vaccination is a powerful tool, but when transmission is high, as it is now, vaccination is not sufficient, and we need to use additional protective measures to lower the risk, particularly for the most vulnerable. Masking and testing are both tools that can interrupt transmission and thereby reduce risk. Masking lowers risk in two ways. It provides what some call source control, meaning controlling the amount of virus that enters the environment right at the source. When people who are infected wear a mask, they exhale far less virus into the air than infected people who do not mask. Masks also provide protection to the individual that's wearing a mask by filtering virus from the air as they're breathing. When everyone in the room is masked, safety is enhanced as there's less virus circulating and less likelihood that any virus that is circulating will penetrate the physical barrier of a well-fitting, high-filtration mask. We continue to strongly recommend testing if exposed, if symptomatic, and right before gathering with others, especially if indoors, and particularly when gathering with anyone at higher risk of severe illness should they get infected. If attendees at a gathering have all tested negative prior to getting together, it's much less likely that anyone will be exhaling virus particles into the air. As a reminder, you can be contagious for COVID and not have any symptoms. That can happen very early in your infection before symptoms start, or it can happen if you have an asymptomatic case of COVID. In contrast, without testing before gathering, given the high levels of transmission, it is more likely that someone who is infectious with the virus will be present and obviously exhaling virus into the air that's around them and you, particularly when indoors. Next slide. To get good protection from a mask, you need both good filtration and a good fit or seal around the edges. The best filtration material is provided by medical masks, such as surgical masks, procedure masks, and respirators. These are all made of materials that are best able to filter out viruses. They also usually have a nose wire to better conform to the shape of your face. Overall, well-fitting respirator-type masks, such as N95s, KN95s, and KN94s are the best choice for masking. The material is thicker in respirators and does the best job at filtering out the virus. Note that you should not double mask with a respirator. Medical masks, such as procedure or surgical masks, can also provide very good protection if you take a few extra steps to improve the fit. One way to do that is to put a cloth mask on top of the medical mask. This is known as double masking. This helps hold the edges of the medical mask to your face and creates a better seal. You can also improve the fit by wearing a mask brace that holds the edges of the medical mask closer to your face, or by making a knot in the ear loops close to the edge of the mask and tucking in the excess material. Wearing a medical mask that's loose or has gaps around the edges still provides some protection, but significantly less than a well-fitting mask. A cloth mask that has at least 3 layers provides minimal protection. And while it's better than wearing no mask, given that we have a highly transmissible set of variants circulating, upgrading your mask makes a big difference in the level of protection. Bandanas, gaiters, and thin cloth masks are not effective at filtering out the virus. For people who cannot wear a mask due to a disability or a medical condition, face shields with drapes that go under the chin and are attached at the bottom edge can provide additional protection. Please check the fit of your mask every time you put it on, and please wear the mask over both your nose and your mouth. Disposable masks and respirators that become wet or dirty should be thrown in the trash and replaced with a dry, well-fitting, high-filtration mask. Next slide. As it's likely that we'll need to return to universal indoor masking in the near future, I want to close by noting a couple of things. First, please remember that indoor masking at this moment is a required safety measure that's in place at many sites. Indoor masking is required in all healthcare settings, public transit and transit hubs, long-term care settings, shelters and cooling centers, and correctional facilities. Businesses and employers are allowed to require masks at work, and many have done just that, either by maintaining an indoor masking requirement throughout the pandemic or reinstating one as cases began increasing. Indoor masking also continues to be required at work sites with outbreaks, and it's required for all individuals during the 10 days after a COVID diagnosis or exposure when they're around others. Second, if we do remain in the high community level for the next 2 weeks, indoor masking, beginning on July 29th, would expand to include all indoor spaces, including shared office spaces, manufacturing facilities, retail stores, and at indoor events. Indoor areas of restaurants and bars, children's programs, and educational settings would also need to institute universal indoor masking as well. As a reminder, masks would not be required for those under 2 years old and those using outdoor spaces where the risk of transmission is significantly lower than indoors. Masks would also not be required indoors for those who are actively eating or drinking. I recognize that when we return to universal indoor masking to help reduce high spread, for many, this will feel like a step backwards. For others, indoor masking will feel unnecessary because of the availability of powerful vaccines and therapeutics. The reality is that because we're living with a mutating SARS-CoV-2 virus, there remains uncertainty around the trajectory of this pandemic. The best way to manage the uncertainty and to reduce morbidity and mortality is to remain open to using both the sophisticated tools we now have, our tests, our vaccines, our therapeutics, and the non-pharmaceutical strategies, masking, ventilation, and distancing, to layer on protections to respond to the conditions at hand. One thing I feel certain about is that given the rich toolkit we have, we should not settle for the existing high rates of morbidity and mortality that disproportionately affect those most vulnerable. We do need to continue to take care of each other and reduce the illness and death that some are experiencing. With the high rates of transmission fueling the increased risks, sensible safety precautions that can slow down the spread of the virus are warranted, and that includes universal indoor masking. In anticipation of the need to return to universal masking, we have begun reaching out to our many community partners, as well as continuing to host multiple meetings and telebriefings for different sectors. We're also updating our guidance and preparing materials in multiple languages that provide more detailed information on requirements related to indoor masking. Free masks may be available for small businesses and community organizations by contacting ppeunite.org. I'm going to say that again, ppeunite.org. Before closing, just a quick update on Novavax. The FDA granted emergency use authorization for the Novavax vaccine earlier this week. CDC's vaccine committee will meet on July 19th to discuss the clinical recommendations. Per the New York Times, we've heard that the federal government is buying 3.2 million doses, with more doses going to states that have more unvaccinated adults. It was approved for use in adults 18 and older as the primary vaccine series. It's not been approved as a booster. It is a 2-dose vaccine with the doses given 3 weeks apart. As a reminder, Novavax was created using a recombinant protein technology that's been used before in other vaccines, such as for hepatitis B. We'll update you as more information becomes available about when we can expect doses to be here in LA County. In closing, thanks to everyone for doing your part to protect yourself and others, especially as we continue to see increases in cases and hospitalizations. Thanks for getting vaxxed and boosted, for masking, staying home when you're sick, and getting tested. Your care and consideration do make a difference, and they help protect our entire community from the worst impacts of the pandemic. Thanks, and I'm now happy to answer questions.
Thank you, Dr. Ferrer. As a reminder, if you have a question, you can chat me, the host, or you can use the hand icon. Our first question is going to come from Marla Tejas from Fox 11. And I scrolled past your name. There we go. Marla, you're unmuted. Go ahead.
Okay, hi, Kim, thanks so much. And Dr. Ferrer, thank you very, very much. Before I actually ask my formal questions, can I just get a clarification? I think we all would like to know is if in fact it does go into effect July 29th, would it expire then when we drop down to the medium level? And would we need to stay at the medium level for 2 consecutive weeks in order for it to drop or to expire?
Yeah, it's a great question, Marla. I mean, we have set the threshold at expiring automatically 2 weeks after we meet the medium threshold. We're happy to take that under advisement. At the time we set the thresholds, there was a lot of up and down that was going on in our cases and our hospitalization numbers. We have much less up and down right now. We pretty much have just a steady increase at the moment. And, were we to be in a situation where we had a steady decrease, we'd certainly be willing to revisit that, but we would need to get down to that medium transmission level. So thanks for bringing that up.
Our next question comes from Ron Lin from the LA Times. Ron, you're unmuted. Go ahead.
Hi, Dr. Ferrer. Thanks very much for taking our questions. Really appreciate it. First, we have a crystal ball question and one's on compliance gyms and waiting for 2 weeks. So first, while we know hospitalizations are worsening here, the state's ensemble hospitalization model suggests hospitalizations will peak around July 24th. What's your degree of certainty on whether we'll stay in the high community level and a mask mandate will be triggered? Second, there's a lot of denial out there about pandemic indicators, and people have pointed out to me that there isn't great adherence to mask wearing at airports. How prepared do you think people will be to accept the order and follow it? Are you concerned people will ignore it? Third, Alameda County has, when they had their brief mask mandate last month, they exempted gyms and yoga studios. Would you do the same? And then finally, it's a question of why wait 2 weeks? I vaguely recall earlier in the year, you had an easier threshold to implement a mask mandate, just hitting the high community level and then it going to effect. What's the rationale for waiting 2 more weeks to do so? Thank you.
Yeah, thanks so much, Ron. Let me just start with the last one, why we're waiting 2 weeks. There are a couple of, just reasonable steps that we're trying to take. One is we always need to give our businesses some ability to go ahead and make some changes. So we're very cognizant of that. And again, I want to go back to what I was talking with Marla about, which is, when we were looking at these thresholds of just even a few weeks ago, we had a lot of, sort of up and downs, like small up and downs. And the last thing we want to do is, tell people that we need to do something, and then a week later or 2 weeks later, we're in a very different place. So we want to make sure that this is in fact a time where we'll be in high transmission, and it makes sense for folks to go ahead with that universal indoor masking. I do want to emphasize, we have never stopped for a moment for the last few months telling everyone that we strongly recommend you wear a mask when you're indoors. So nothing has changed on that recommendation. I think for those folks that are looking at our data, seeing at this point, pretty steep increases in case numbers, knowing that that's a serious undercount of how high transmission actually is, you would, for your own safety, the safety of your family, the safety of people you are with, and the safety of those most vulnerable, you won't wait the 2 weeks to go ahead and put that mask back on when you're indoors. Because again, we have a ton of transmission right now. In terms of the July, the modeling that shows a July 24th peak in hospitalizations, I have a hard time understanding how, for LA County, we would peak on July 24th. Hospitalizations are generally a lagging indicator. Case numbers are still going up for us. So if you want to look at the ratio and say 1.5% of our cases end up hospitalized, but it's a 2-week lag, I continue to see us, given the significant increase this week, that 2 weeks out from now, we are still seeing a lot of hospitalizations. So not sure about that peak designation being just a short while out for LA County. Now, if our numbers start going down next week, then I do think it's reasonable to say a few weeks after that, hospitalization numbers should go down as well. In terms of compliance, We've always benefited in LA County from most people actually going ahead and complying with what we say are sensible precautions, particularly now when what we're asking for is something as simple as putting on that high filtration, well-fitting mask over your nose and mouth. And we, will be spending these 2 weeks working with our businesses so that they're clear about their need to both supply those masks for all of their employees, make sure that their employees are masked appropriately indoors, and to do their best to message to their customers. We have never issued individual citations to people who have decided not to wear that protective mask. We ask that everybody do their part. We've had very high rates of people doing their part. I think you're right to note that many people feel like the risk is a lot lower right now and there's no need to worry. We're saying there is need to worry. This variant is, as everybody has noted, highly infectious, easily transmitted from person to person. We need an additional layer of protection. And this is the additional layer. So, our hope is that folks will go ahead and make every effort to come into compliance, because it's a sensible thing to do. And we'll again work with all of our sectors to make sure they have good information, they have access to the good signage. We'll spend these 2 weeks making sure people know that we're moving in this direction so that people can be well prepared. We are not offering exemptions for gyms. I'm not sure what else you mentioned, and yoga studios at this time. Again, spread is super high everywhere. We have lots and lots of outbreaks. So we are going to just ask that everybody go ahead with that indoor masking or move those indoor activities outdoors. And then you can leave those masks off. So thanks, Ron.
Dr. Fair, we're going back to Marla, who
Yeah, I
has
was
an
going to
additional
say,
question. Yes, my
question.
apologies. Marla, go ahead.
Thank you. Thank you so much. It seems just in how you're presenting this that it's pretty certain that that indoor mask mandate will return July 29th. Is it too late to reverse course? Is there a way out of this? That's question one. Question two is, you talk a lot about equity, which we appreciate. You say it's paramount when explaining why this mask mandate is necessary, knowing that other surrounding counties are not reinstating it. So is it fair, Dr. Ferrer, to say that your number one motivating factor to implement the indoor mask mandate again is to protect essential workers? Thank you.
Yeah, thanks so much. Those are great questions. It's never too late to reverse course. As I noted in response to Ron's question, because we moved into high based on a hospital metric, new hospital admissions, and hospital metrics are lagging often from our high case numbers. Given that our case numbers are still going up, it's hard to imagine that 2 weeks from now, the hospital admission data metric will drop, because that's what we would need to drop. We need to go below 10 new admissions. Is it possible? Absolutely. I mean, nothing's impossible, but at this point, it's much more likely that we will move into high. That will stay in high for these 2 weeks, and therefore we'll need that universal indoor masking starting on July 29th. Again, I appreciate that question that you started with, because there is variability, and should we start a decline pretty soon, then we could quickly move out of being in the high community level and go back to the medium community level where the risk would obviously be lower. And your second question is a really important question. Lots of folks are asking, why we're bothering and why don't we just let things run their course like other places may have done. I think it's really hard if you're in public health to look at our data, and that's our responsibility to look at the LA County data, not notice who continues to be hardest hit, and not notice that we still have like lots and lots of people with severe illness, lots of people who die, and lots of people with long COVID, and not want to take a fairly straightforward step to try to layer in some additional protections. We are not closing anything down. We are not asking people not to gather with the people they love. We are not asking you to forego activities you love. We're asking you to take a sensible step when there's this much transmission with a highly transmissible variant to go ahead and put back on a well-fitting, high filtration mask when you're indoors around others. And I think that's the prudent thing to do. And to do it so that we do both, protect all of us. I mean, it's protection for everyone. You cannot predict with any degree of certainty whether if you get infected, you're going to be one of the luckier ones that ends up with mild illness or one of those that ends up with severe illness. Every day when I report out who dies, there are people who die who have no underlying health conditions. So no one should go in the space of saying, I'm not at any risk, because that's just absolutely not true. And we do know that some people are very high risk, and they're people we love. There are older people in our families, there are older people vulnerable in our nursing homes. I think we kind of owe it to each other to do whatever we can to reduce that burden and to really acknowledge that it has disproportionately affected people who are either older, have serious underlying health conditions, or have more exposures, which tends to be people who, like you noted, are essential workers. So I think we take this step because we think it makes sense for all of us to continue to do everything we can to reduce this high rate of morbidity and mortality. This is not the flu, and this is not a cold. We have way more serious illness and death associated with COVID than we do for colds or for the flu. So I think we need to continue to protect each other. But thanks for those questions.
Our next question comes from Lauren Leister from KTLA. Lauren, you're unmuted. Go ahead.
Thank you so much for taking my question, Dr. Ferrer. I wanted to ask you, I was speaking to an infectious disease doctor and scholar at Johns Hopkins who it was his premise at this stage with this variant, yes, hospitalizations will tick up, but we won't be in a situation where we're worrying about PPE or ICU beds or ventilators. And then at this stage in the pandemic, we're not likely to see hospitals in crisis given all of the tools that we have at this point. Is that the premise that you are operating under with where we're at here in LA County with this variant?
I think, I mean, you noted in my response to the last question, I didn't say we're doing this because this will, guarantee that we're going to reduce stress on the healthcare system. I think that's an important consideration, but it's not the only consideration. I think we should do everything we can to reduce preventable illnesses and deaths associated with COVID still, especially when we have some tools that we could use. But I do think that there's a degree of accuracy in noting that the tools that we do have, vaccinations, boosters, and therapeutics, are making it much less likely that large numbers of people currently are needing to use the ICUs or ventilators. Our data shows that as well. Our numbers have stayed fairly steady. I do want to say they're not zero. Somewhere between 5 and 10% of folks that are hospitalized with COVID are still ending up in the ICU, and some of them are needing ventilators. So there still is some serious, again, illness associated with COVID, but nothing like what we were seeing during the Omicron surge. And even severity of illness that we saw at our hospitals, I think, was more frightening during Delta. But we also have a lot of unknown with BA.5 and anything else that comes our way, as we all know. So I also want to note that, what's going on in our hospitals could change. We're also well aware that hospitals aren't the only place where there's stress, that emergency departments and urgent care centers and community clinics are telling us that they're feeling very strapped. They have staffing shortages because lots of their staff are sick with COVID and out. And they also have lots of their patients that while they don't need to go to the hospital, they do need medical care, and that creates some stress as well. But thanks, Lauren, for that question.
Our next question comes from Christine Maiduk. You are unmuted, Christine. Go ahead.
Hi, Dr. Ferrer. I just wanted to know if you had any more information you could share
about the BA 2.75 case in LA County, or the other case, I guess, in another part of California. Are those travel related? Is there any concern yet in terms of what we're finding in California?
No, I don't really, I don't really have the details on our case at the moment. I will say, small numbers, but why we track, because, a month ago, we had very small numbers for BA.4 and BA.5. So we see spread in India. We've had other variants of concern that have spread from India across the world and caused, significant illness and deaths. So we're going to continue tracking, but I don't have specific information, particularly on your question about whether these two people were travelers. I think, we'll have more information, obviously, next week. So these are cases that just got reported.
Dr. Ferrer, your audio is cutting out a little bit.
Oh,
Can you
sorry.
unmute and unmute yourself real quick? See if that fixes it.
Is that better?
That's a little bit better. Yes.
Sorry.
No
Obviously,
problem.
I'm having some problems with my connection. So,
Our next question comes from Margaret Carrero from KNX. Margaret, you're unmuted. Go ahead.
Thank you so much, Dr. Ferrer. Couple things real quickly here with regard to the COVID and the rising cases and everything we're seeing. What, if anything, would prompt a shutdown at this point? That's the only COVID question I have for you. And then monkeypox. I want to address monkeypox. AIDS Healthcare Foundation coming out today. They put out like a 6-point plan for the public health department as far as the response to monkeypox. And a couple of those, they would like to see like twice weekly briefings on the number of new cases and where they're occurring. Also talking about wanting the public health department to lobby the federal government to supply vaccine on an emergency basis. Are any of those things even possible at this point?
yeah, thanks so much. Let me go back to the first question, and then I'll on COVID, and then I'll come to monkeypox. And Kim, let me know if I continue to fade in and out. I'm trying to get closer to the TV here, to the monitor.
You sound great right now.
Okay. So in terms of the first question about, do we ever see a time we'd have to like shut down again? I mean, I would say, probably not. But again, like so much uncertainty and, with the mutations, I never want to say never, but we have really, really good tools that ought to make it unlikely that we have to go back to, completely separating ourselves from each other to avoid the spread, and obviously the caveat is if there was some mutation that evaded very significantly the protections we now have from the vaccines for severe illness and deaths. So we start seeing something that isn't providing us with any significant protections, then, we all are going to go back to the drawing board to try to figure out what we need to do. But that, I think, is an unlikely scenario. We have lots of people working to update the vaccine. So, and our therapeutics, our testing, like there's so many people that are working to make sure we don't have to worry about not having these tools, these pharmaceutical tools that really provide us with a lot of powerful strategies for, in fact, reducing the threat from this virus. So I think in general, no, I don't see us returning. Could there be some highly unusual, highly unlikely situation? Yes, but I think would be just that, very unusual, very unlikely, given what we've seen so far. I haven't seen the request for, or the 6-point plan. I will say that I think we are already planning to do regular briefings and appreciate that is one way for us to easily be able to keep people informed. We're also working with many of our partners on other ways to keep people informed who may be less likely to listen into those briefings. And, I think we work closely with the federal government to, advocate that we get increased supplies of this vaccine. for everyone. I mean, not just LA County. I mean, everyone who's at higher risk for monkeypox is looking, as people have looked in the past for a COVID vaccine, is looking to be offered that opportunity. You know, I want to continue to note that we're urging people, since we don't have an ample supply of vaccine, to take a look at all the information that's out there about how you can protect yourself in the absence of there being accessibility for everyone who may want a vaccine to get vaccinated, and working closely with our providers so that we can provide the best care and be able to obviously test and diagnose cases very rapidly. So, but, you know, appreciate all of our community partners and their willingness to work hard together to keep the communities well informed and to make sure we're doing everything we can to mitigate the spread of monkeypox as well. So thanks for that. And I probably, I don't know where we are on folks in the queue, Kim, but I probably only have time for one more question.
Okay.
Sorry.
Our final question, of course, is from Emily Albert Reyes from the LA Times. Emily, you're unmuted. Go ahead.
Great, thank you so much. I want to, is the county pursuing any efforts to improve ventilation in public spaces in light of the level of transmission happening right now?
Yeah, it's a great question, Emily. I think, you know, we definitely have a lot more materials out there. I mean, we think ventilation indoors is critical. And we're hoping, you know, obviously that Cal OSHA and federal OSHA, you know, also take a really good look at what we could all do to improve indoor air quality at our work sites and at our schools and places where people are gathering. The biggest, you know, I think the place where we're really working the hardest right now is there's a toolkit that we've been circulating with schools, because there are actually some fairly simple, not so expensive steps that our schools could take as they prepare to reopen later this summer and the fall that would improve ventilation. So I love this question because I think we often don't talk a lot about ventilation, but there are some strategies that are not super costly that, as you noted, would improve the air quality and reduce, again, exposures to aerosolized virus. So thanks for that. And I want to thank everyone. Appreciate your joining us today. And if we didn't get to your questions, please send them in and we'll respond immediately. So thanks a lot, folks.
Thank you, Dr. Ferrer, and thank you to everyone who joined us today. As Dr. Ferrer mentioned, you can send in your additional media questions to our media inbox at media@ph.lacounty.gov. If you'd like to stick around, we'll have Spanish remarks in just a few minutes. Hello, Deanna, are you there?
Hello, I'm here.
Hi, do you think you're ready to start?
I'm ready.
Okay, one moment. Good afternoon, everyone. Thank you for joining the Public Health Department for the Spanish portion of today's media briefing. We have Deanna presenting. Deanna, please begin when you're ready.
Thank you so much, Kim. Muy buenas tardes y gracias por acompañarnos durante esta sesión informativa. Hoy daremos un informe sobre el estado de COVID-19 para el condado de Los Ángeles. También discutiremos el requisito universal del uso de mascarillas en interiores, que es muy probable y puede llegar en las próximas semanas. First slide, please. Bueno, como verá, los casos, las hospitalizaciones y las pruebas con resultados positivos siguen elevados. Hoy estamos reportando 8,535 casos nuevos. El promedio de casos reportados durante la semana, la última semana, estuvo a más de 6,400 casos nuevos por día. Les recordamos que las cifras que estamos compartiendo el día de hoy están subestimadas, ya que no incluyen los resultados positivos de las pruebas de venta libre. La tasa de positividad de la prueba diaria tiene un promedio de 16% esta semana y sigue aumentando, lo que refleja una tasa creciente de transmisión asociada con subvariantes de COVID nuevas y altamente infecciosas. En todo el estado, la tasa de positividad es del 16% y en todo el país es un poco menos del 18%. Muchos proveedores de atención médica en la comunidad nos están informando que están viendo una tasa de positividad de pruebas casi del 40% en pacientes que van a recibir atención médica. Entonces, también estamos viendo aumentos en el número de pacientes hospitalizados con COVID durante la semana pasada. Reportamos 989 el jueves pasado y hoy tenemos a 1,202 pacientes. Alrededor del 42% están hospitalizados con enfermedades relacionadas con COVID. Esta tasa se ha mantenido relativamente estable este último mes. Tristemente, estamos comenzando a ver aumentos en el número de muertes por primera vez desde la oleada del invierno, con un promedio de 14 muertes por día reportadas durante la última semana. Una proporción cada vez mayor está asociada con brotes en lugares para personas de la tercera edad y la tasa de mortalidad por COVID es muy alta. Para aquellos que han perdido a un ser querido por COVID, siguen en nuestros pensamientos, en nuestras oraciones y les deseamos paz durante estos tiempos que son tan difíciles. Next slide, please. Can I get the next slide, please? Can I get slide number 2, please?
Deanna, we're having some delays. I think we're on slide 2.
Great, thank you.
Yeah.
Si observamos las líneas de tendencia del último año de los casos diarios con la línea verde, los ingresos hospitalarios con la línea anaranjada y las muertes con una línea azul, podemos ver claramente que nuestro aumento es similar al aumento impulsado por Delta que vimos el verano pasado. Desde los casos diarios alcanzaron un máximo de 3.500 y las admisiones diarias en hospitales alcanzaron un máximo de 215. Y como muchos recordarán, con el aumento de casos el verano pasado, con enfoque en el 17 de julio del 2021, el uso universal de mascarillas en interiores se implementó para todas las personas mayores de 2 años en el condado de Los Ángeles como medida de protección. Aunque no podemos compararlos completamente, sí estamos viendo números de casos mucho más altos que los que vimos durante el pico de la oleada de Delta. Es un poco probable que estemos en el punto máximo de este aumento reciente, lo que da lugar a una mayor circulación de nuevas subvariantes alarmantes y eso pues ya llegamos a un promedio de más de 6.400 casos reportados por día. Y aunque nuestro número promedio de ingresos hospitalarios es de 157 por día, aún no hemos alcanzado el nivel máximo, que es de 215 por día, algo que sí fue visto durante el aumento de Delta. Con el aumento de las hospitalizaciones es posible que veamos los números similares en las próximas semanas. Como señalamos anteriormente, aunque muchos de los hospitalizados no están ahí debido a COVID, las cifras crecientes indican que para muchos COVID sigue siendo un virus muy peligroso. Next slide, please. En adelante vamos a ver la tabla de niveles comunitarios. Y pues vamos a seguir investigando el impacto de la pandemia en el condado de Los Ángeles utilizando el marco de niveles comunitarios COVID-19 de los CDC. Es una manera de medir la presión y el estrés dentro del sistema de atención médica causadas por el COVID-19. Este marco de niveles comunitarios se utiliza como una métrica de tasas de casos y hay 2 métricas de hospitalización. Reportamos el día de hoy que a partir de este día hemos pasado del nivel comunitario medio al nivel comunitario alto. La primera métrica en nuestra tasa de casos de 7 días es de 370 casos por semana por cada 100,000 personas. Usando datos específicos del condado de Los Ángeles, estamos en 10.5 admisiones por cada 100,000 personas. Este es un aumento del 88% en comparación con el reporte de hace una semana. Dado que esta métrica se ha movido por encima del número 10 por semana por cada 100,000 personas y nuestra tasa de casos también está por encima de 200 por semana por cada 100,000 personas, hemos pasado al nivel comunitario alto. La segunda métrica hospitalaria en el marco de niveles comunitarios de los CDC es el promedio de 7 días sobre la proporción de camas de hospital ocupadas por pacientes con COVID-19. Actualmente, el 5.4% de las camas están ocupadas por pacientes con COVID en el condado de Los Ángeles, un aumento del 84% en comparación con los números de hace un mes. Como mencionamos en reportes anteriores, si seguimos en el nivel comunitario alto durante 2 semanas seguidas, o sea, del 21 y el 28 de julio, tendremos que implementar el uso de mascarillas al entrar a cualquier lugar para ayudar a reducir la tasa de transmisión y para proteger a los más vulnerables. Hablaremos un poco más sobre este punto en unos minutos. Next slide, please. Seguiremos con las señales de alerta temprana. También vamos a ver que estamos indicando un riesgo elevado en nuestro condado asociado con la propagación de variantes altamente contagiosos. Esto tiene un impacto alarmante en los sitios de trabajo y entre los residentes de hogares para personas de la tercera edad. Como muestra la tabla, 4 de las 7 métricas de alerta temprana que estamos investigando transmiten inquietud alta. Vemos las nuevas variantes que causan inquietud, las tasas de casos en áreas con mayor pobreza y los brotes en centros de cuidado especializado y en los grupos de casos en sitios de trabajo. Dos alertas tempranas que transmiten preocupación a nivel alto son el porcentaje de visitas al departamento de emergencias relacionadas con el COVID-19 y la cantidad de brotes en entornos que atienden a personas sin vivienda. Y aunque no reportamos ningún sistema de aguas residuales que haya pasado por un aumento del doble en carga viral durante las últimas 2 semanas, nos faltan datos sobre 2 sistemas muy grandes y porque no tenemos estos datos, pues vamos a repasar algunas métricas en las próximas gráficas. Next slide, please. Aquí vamos a ver los porcentajes por variante en un minuto. Vamos a ver que Omicron sigue representando el 100% de las muestras secuenciadas. Sin embargo, las proporciones de las subvariantes continúan evolucionando. La inquietud viene con el aumento constante en las proporciones de las subvariantes BA4 y BA5, como lo muestran las secciones en color rojo en la parte superior de cada barra. En la semana que terminó el 25 de junio, BA4 y BA5 representaron el 62% de todas las muestras secuenciadas, más del doble en comparación con la cifra de hace 2 semanas. BA5 avanza con el 48% de todas las muestras secuenciadas. Y es que los CDC estiman que en todo el país, a partir de la semana que terminó el 9 de julio, las subvariantes BA4 y BA5 de Omicron combinadas representaron un poco más del 81% de las muestras, un aumento considerable del 53% solo 2 semanas atrás. Tanto en los datos nacionales como en los datos del condado de Los Ángeles, BA4 y BA5 continúan superando la subvariante BA2 y sus sublinajes. Como podrán ver aquí, la subvariante BA5 está creciendo más rápido que la subvariante BA4. Tanto la BA4 como la BA5 son motivo de inquietud muy alta debido a su capacidad para esquivar la inmunidad previa y por lo tanto pueden volver a infectar a las personas que estuvieron infectadas con otras subvariantes de Omicron. Es muy probable que el aumento en la circulación, particularmente de la BA5, ayude a crecer el nivel de riesgo de infección entre muchos en nuestra comunidad. Además, hace unos días la OMS subrayó la propagación de un sublinaje nuevo de la subvariante Omicron BA2. Esta se llama BA2.75, de nuevo BA2.75, y es considerada un linaje bajo monitoreo por la OMS. Parece tener evoluciones adicionales que facilitan la transmisión y evaden la inmunidad. Y se ha estado propagando en India. Y aquí en los Estados Unidos estamos identificando 6 casos, con 2 aquí en California y uno de estos casos está en el condado de Los Ángeles. Cada vez que se identifica una nueva variante es muy alarmante y debemos proceder con precaución, ya que lleva tiempo entender los riesgos que plantea la virus recién transformada. Se necesita tiempo para determinar con certeza la capacidad de una virus recién cambiada para ver cómo puede evadir las protecciones de inmunidad, infectar fácilmente a otros y causar enfermedades graves. Hasta que tengamos una idea de cómo el virus está interactuando con nosotros, usar protecciones sensibles sigue siendo una buena idea. Next slide, please. Y bueno, con casos elevados, nuestro departamento de emergencias y centro de atención urgente atienden a más personas que necesitan atención médica debido al COVID. Como muestra esta gráfica, la línea azul muestra el porcentaje promedio móvil de 7 días de visitas al departamento de emergencias relacionadas con COVID entre el 1 de marzo y el 10 de julio de este año. La proporción de casos de urgencias que involucran a personas que buscan atención médica por COVID ha subido y ahora está justo por debajo del umbral, cambiando de nivel medio a nivel alto. Esto indica que el COVID está ejerciendo una presión cada vez mayor, más grande, sobre nuestros sistemas médicos a medida que aumenta la transmisión viral y que muchas personas infectadas se sienten bastante enfermas como para necesitar atención médica de emergencia. Next slide, please. Lo que vamos a ver en estas próximas dos gráficas son los últimos datos sobre las concentraciones de aguas residuales de SARS-CoV-2 en los dos sistemas que están reportando datos actualmente. Los otros dos programas o sistemas tuvieron un retraso en las pruebas y los reportes y esto es debido a una escasez en la cadena de suministro de prueba a nivel estatal. Esperamos poder informarles sobre estos datos la próxima semana. Para el Distrito Municipal de Agua de las Vírgenes, que sirve a la ciudad de Calabazas y sus alrededores, se puede ver un aumento en las concentraciones virales de aguas residuales desde la segunda semana de junio, aunque la carga viral no se duplicó en comparación con el promedio de hace 14 días. Next slide, please. La próxima gráfica que vamos a ver muestra los resultados de las concentraciones virales de las aguas residuales en la planta del Distrito Sanitario del Condado de Los Ángeles en Lancaster. Aquí vamos a ver un aumento más pronunciado. Si bien tenemos que aprender aún más sobre el monitoreo de aguas residuales, el examen de la carga viral brinda una forma prometedora de integrar los datos de las pruebas y fortalecer nuestras investigaciones para que podamos entender los niveles de transmisión comunitaria de más profundidad. Next slide, please. En un momento vamos a ver también el aumento de casos en la comunidad que está a mayor riesgo de infectarse. La cantidad de brotes nuevos por semana en los centros de cuidado especializado, como verán con una línea morada, sigue siendo motivo de preocupación alta y sí, ha habido cambios en la métrica durante las últimas semanas, pero ahora estamos viendo una cantidad alarmante de brotes en centros con 41 brotes solo en la semana pasada. Muchos de estos brotes incluyen a 15 casos o más. Cuando surge un aumento en casos, los más vulnerables a menudo se ven afectados de manera extremada. Un hallazgo alarmante que estamos viendo es un mayor porcentaje de muertes asociadas con brotes en sitios de cuidado especializado. En mayo, casi el 5% de todas las muertes sucedieron entre los residentes de hogares para personas de la tercera edad, para las personas de la tercera edad. Esto es un aumento al 12% en junio. Este riesgo creciente también se refleja en la proporción de muertes por COVID entre las personas de 80 años en adelante, que subió del 44% en mayo al 58% en junio. Los centros de cuidado especializado continúan brindando mejores protecciones para los residentes y para el personal. Sin embargo, una estrategia eficaz para reducir este número se encuentra en reducir la tasa de transmisión a nivel comunitario. Next slide, please. También vamos a hablar un poco sobre los casos en sitios laborales. Hemos visto un aumento constante en los reportes de grupos de casos en sitios laborales desde fines de abril. Como podrán ver en una línea rosita, los grupos de casos en sitios de trabajo han sido motivo de gran inquietud durante las últimas 4 semanas. La semana pasada recibimos 371 reportes de brotes en sitios de trabajo, lo que representa un aumento del 43% con respecto a la cantidad de brotes reportados hace un mes. Estos números reflejan el aumento de casos en todo el condado. Los brotes en sitios de trabajo son peligrosos, especialmente muchos de estos brotes involucran a 20 trabajadores o más. El personal necesita usar su tiempo abruptamente para aislarse, para faltar al trabajo, para recuperarse, lo que genera una escasez de personal y obstáculos en las operaciones del día al día. Los brotes en sitios de trabajo crean un riesgo alarmante para trabajadores vulnerables y a menudo contribuyen a la transmisión del virus en muchos hogares y en sus comunidades. Les recordamos que todos los sitios de trabajo en el condado de Los Ángeles deben informar a Salud Pública si han tenido 3 o más casos en las últimas 2 semanas, porque esto puede indicar la posibilidad de que han tenido un brote. Next slide, please. Y bueno, queremos hablar un poquito más sobre la información que está circulando ahorita, ¿verdad? Está circulando mucha información incorrecta sobre COVID, incluso que en este momento solo causa una enfermedad bien leve. Desafortunadamente, esto no es cierto y el COVID sigue siendo una de las causas principales de fallecimiento en el condado de Los Ángeles. Como podrá ver en esta gráfica, COVID ha causado miles de muertes cada año y la cantidad de muertes por COVID este año a causa de la variante Omicron y sus subvariantes sigue alta. Ya superó las 4,400 y nos queda muy claro que esta cifra aumentará. Hemos visto más muertes por COVID en los últimos 6 meses que las que hemos visto anualmente por cualquier otra enfermedad infecciosa y más de 3 veces las muertes adicionales por COVID que las que hemos visto en promedio durante una temporada de gripe prepandémica. Las muertes anuales por COVID también son sumamente altas a comparación con las muertes anuales por sobredosis y accidentes automovilísticos. Como comunidad, tomamos muchas medidas de protección para reducir las muertes por vehículos motorizados que todos deben seguir, incluyendo las normas de tránsito, los requisitos de seguridad en el automóvil, las limitaciones en el consumo de alcohol para los conductores y el uso de cinturones de seguridad obligatorio. Como podemos ver en esta tabla, el COVID también todavía presenta riesgos muy peligrosos, así que es apropiado tomar acciones colectivas sensatas para reducir la transmisión del virus. Estas medidas son similares al enfoque que estamos tomando para prevenir lesiones o muertes por vehículos motorizados, como las explicamos. Next slide, please. Y es que con el kit de herramientas que tenemos a nuestra disposición, las protecciones sensibles se dividen en 2 categorías que veremos muy pronto. Hay estrategias para reducir la gravedad de las enfermedades y las muertes y hay estrategias para reducir la transmisión. Los dos enfoques están sumamente relacionados y ambos son esenciales para reducir la desproporcionalidad y proteger a los más vulnerables. Sabemos que no nos enfermamos si no nos infectamos, por lo que frenar la transmisión siempre será una estrategia fundamental para enfrentar al COVID. Cuando la transmisión es alta, muchas personas están expuestas y se infectan, lo que crea más riesgo para los demás, especialmente para los más vulnerables. El uso universal de mascarillas y el uso de pruebas son herramientas eficaces para reducir la transmisión viral. Las mascarillas brindan una barrera física y las pruebas le permiten a una persona conocer su estado para que evite infectar a otros. Y aunque las vacunas y los medicamentos no son efectivos al 100%, las vacunas, los refuerzos y los medicamentos brindan una protección más fuerte contra enfermedades graves, contra hospitalizaciones y muertes. Estas medidas no solo ofrecen protección a las personas que reciben la vacuna o el tratamiento, sino que también protegen a otros en la comunidad y reducen el estrés en nuestro sistema de atención médica. Next slide, please. Y si bien todos conocemos a muchas personas, incluido nosotros mismos, que estamos vacunados y que quizás se infectaron con COVID, sería incorrecto suponer que las vacunas no están funcionando. Aunque las vacunas no previenen la transmisión de COVID completamente, son muy efectivas para reducir el riesgo de desarrollar una enfermedad grave y morir. Esto es algo que podemos ver cuando comparamos las tasas de casos, hospitalizaciones y muertes en residentes vacunados y no vacunados. En esta gráfica que estamos viendo, podemos usar el término y vamos a usar el término completamente vacunados para incluir a aquellos que cumplieron con su serie inicial de vacunas y que también a lo mejor se pusieron el refuerzo o refuerzos o no. Durante el periodo de 30 días que terminó el 28 de junio de este año, los residentes no vacunados tuvieron alrededor de 1.5 veces más probabilidades de infectarse que las personas que se pusieron todas las vacunas. Y si bien esta diferencia no es enorme, sugiere que incluso con las subvariantes más infecciosas de Omicron que se han propagado en el condado de Los Ángeles, las vacunas aún brindan cierta protección contra la infección. Durante este mismo periodo de tiempo, los residentes del condado de Los Ángeles que no se vacunaron tuvieron 4 veces más posibilidades de ser hospitalizados con COVID que los residentes que se pusieron sus vacunas. Y los que no estaban vacunados en el condado de Los Ángeles tuvieron casi 7.5 veces más probabilidades de morir de COVID que los residentes vacunados. Next slide, please. A medida que alineamos los esfuerzos en el condado para proteger a los más vulnerables durante estos tiempos, seguimos notando el impacto desproporcionado de COVID entre algunas comunidades, incluidas aquellas comunidades con altos índices de pobreza. Estas tablas muestran las tasas de hospitalización y muertes por COVID según el estado de vacunación para 4 niveles de ingresos comunitarios distintos. Las cifras cubren un periodo de 90 días que terminó a fines de junio. Y como podrán ver aquí, las vacunas ofrecen una protección contra las enfermedades y enfermedades graves, ya que las personas recibieron todas sus vacunas, fueron hospitalizadas y fallecieron a un ritmo mucho menor que las personas no vacunadas en comunidades con niveles de ingresos similares. Sin embargo, las vacunas no son un ecualizador y las diferencias persisten entre las personas vacunadas. Las personas vacunadas que viven en comunidades donde el 30 al 100% de los hogares que viven en la pobreza tienen casi 1.5 veces más probabilidades de ser hospitalizadas y casi 2 veces más probabilidades de morir que las personas vacunadas que viven en áreas con menos de 10% de hogares que viven en la pobreza. Las personas vacunadas que viven en nuestras comunidades con menos recursos tienen tasas más altas de hospitalización que las personas que no son vacunadas, pero que viven en comunidades de ingresos altos. Las personas no vacunadas en comunidades con mucha pobreza tenían cerca de 10 veces más posibilidades de ser hospitalizadas o de morir que las personas no vacunadas que viven en las comunidades con más recursos. Las familias con menos recursos tienen más posibilidades de tener más exposiciones en el trabajo al vivir en lugares más pequeños y con más personas y tener una o más condiciones de salud crónicas en comparación con aquellas más adineradas. Esto pone a las personas en mayor riesgo de sufrir efectos graves de COVID, dado que la vacuna por sí sola no es suficiente para eliminar las inequidades alarmantes. Se necesitan más esfuerzos para proteger a las personas en mayor riesgo. Next slide, please. Y bueno, como acabamos de ver, la vacunación es una herramienta muy buena, pero cuando la transmisión es alta, como lo es ahora, la vacuna no es suficiente y necesitamos usar medidas de protección adicionales para reducir el riesgo para los más vulnerables. El uso de mascarillas y la prueba son herramientas que pueden interrumpir la transmisión, reduciendo así el riesgo. El uso de mascarillas reduce el riesgo de dos maneras. Proporciona lo que unos llaman el control de fuente, con el propósito de controlar la cantidad de virus. Y cuando las personas afectadas usan una mascarilla, exhalan mucho menos virus al aire que las personas infectadas que no la usan. Las mascarillas también brindan protección a las personas que la usan al filtrar el virus del aire que respiran. Cuando todas las personas usan mascarillas, la seguridad mejora, ya que hay menos virus circulando y menos posibilidades de que cualquier virus que circule penetre la barrera física de una mascarilla de filtración superior que esté bien ajustada. Seguimos recomendando que se haga la prueba si está expuesto, si presenta síntomas o justo antes de reunirse con otras personas, especialmente si se encuentra en interiores y cuando se reúne con cualquier persona con mayor riesgo de enfermedad grave en caso de que se infecte. Si todos salen negativos antes de reunirse, es menos probable que alguien exhale partículas de virus en el aire. Como recordatorio, puede ser contagioso y no tener síntomas. Eso puede suceder antes de que comiencen los síntomas de COVID o puede suceder si tiene un caso asintomático de COVID. Por el contrario, sin pruebas antes de la reunión, dados los niveles de transmisión tan altas que tenemos en estos momentos, es más probable que esté alguien infectado con el virus presente en su reunión. Next slide, please. Y pues vamos a hablar un poquito más de las mascarillas. Para obtener la mejor protección utilizando una mascarilla se necesita una filtración buena y un ajuste muy bueno para que se forme un sello alrededor de los bordes. El mejor material de filtración lo tendrán las mascarillas médicas, como las mascarillas quirúrgicas y a esas que se les llaman respiradores. Estos están hechos de materiales que son más capaces de filtrar los virus. También suelen tener un alambre en la nariz para adaptarse mejor a su rostro. En general, las mascarillas de tipo respirador que se ajustan bien, como las llamadas N95, KN95 y KN94, son son las de la mejor opción. El material es más grueso en los respiradores y logra filtrar el virus de mejor manera. Tenga en cuenta que no debe usar mascarilla doble si usa un respirador. Las mascarillas médicas o quirúrgicas también pueden brindar muy buena protección si toma algunas medidas adicionales para mejorar el ajuste. Una forma de hacerlo es colocar una mascarilla de tela encima de la mascarilla médica, también conocida como usar mascarilla doble. Esto ayuda a sujetar los bordes de la mascarilla médica a la cara y crea un sello. También puede mejorar el ajuste usando un aparato ortopédico que sostenga los bordes de la máscara médica para asegurarse que esté cerca de su cara y puede también hacer un nudo en las orejeras cerca del borde de la mascarilla y doblar cualquier material en exceso. El uso de una mascarilla que le quede floja o con espacios alrededor de los bordes aún brinda cierta protección, pero mucho menos que una mascarilla que se ajusta bien. Una mascarilla de tela que tenga al menos 3 capas proporciona protección mínima, pero es mejor que no usar mascarilla para nada. Dadas las variantes altamente transmisibles que circulan, es mejor asegurarse que debemos mejorar el tipo de máscara que usamos, ya que hace una gran diferencia en el nivel de protección. Los pañuelos y otros trapos, las mascarillas de tela delgada, no son muy efectivos para filtrar el virus. Para las personas que no pueden usar una mascarilla debido a una discapacidad o a una condición médica, los protectores faciales le pueden brindar protección. Verifique el ajuste de su tapabocas cada vez que se lo ponga y use la mascarilla sobre la nariz y la boca. Las mascarillas desechables y los respiradores que se mojen o se ensucien deben tirarse a la basura y reemplazarse con una mascarilla seca de filtración alta y que se ajuste muy bien. Next slide, please. Y bueno, ya que es muy probable que tengamos que regresar al uso universal de mascarillas al entrar a cualquier lugar en un futuro cercano, les voy a compartir un par de cosas. Primero, vamos a recordar que el uso de mascarillas en interiores sigue siendo una medida de seguridad requerida en muchos lugares. Y que se requiere el uso de mascarillas dentro de todos los entornos de atención médica, en centros de tránsito y transporte público, en entornos de cuidado a largo plazo, en refugios y en centros para refrescarse durante el verano y dentro de correccionales. Los negocios y los empleadores pueden exigir que use una mascarilla en el trabajo y muchos lo han hecho. Ya se ha mantenido ese requisito de uso de tapabocas en interiores durante la pandemia o se ha restablecido este mandato a medida de que los casos empezaron a subir. También se sigue exigiendo el uso de mascarillas en sitios de trabajo y muchos con brotes y se requiere para todas las personas durante 10 días posteriores a un diagnóstico o al haber sido expuesto al COVID. Se sigue el número de comunitario. Si seguimos así como vamos en el nivel comunitario alto durante las 2 semanas que vienen, el uso de mascarillas en interiores a partir del 29 de julio se va a expandir para incluir a todos los lugares, incluidos los espacios de oficinas compartidas, las fábricas, las tiendas, los eventos dentro de cualquier estructura. Se deberá usar una mascarilla al entrar a restaurantes y bares y durante los programas para niños y en cualquier entorno escolar. Como recordatorio, no se exigirá el uso de mascarillas para los menores de 2 años o para aquellos que usan espacios al aire libre donde el riesgo de transmisión es mucho menor. Tampoco se requerirán mascarillas en el interior para aquellos que están comiendo o bebiendo activamente. Reconocemos que cuando volvamos al uso de mascarillas universal con el propósito de reducir la transmisión y que para muchos esto se va a sentir como un paso atrás. Para otros esto se sentirá innecesario debido a la disponibilidad de vacunas y medicamentos. Y bueno, es que la realidad es que debido a que vivimos en una situación con un virus mutante, sigue la incertidumbre sobre la trayectoria de la pandemia. La mejor manera de manejar la incertidumbre es al seguir dispuestos a usar las herramientas que tenemos ahora, o sea, las pruebas, las vacunas y los medicamentos, como las estrategias no farmacéuticas, las mascarillas, la ventilación, el distanciamiento para responder a las condiciones presentes. Una cosa de la que estoy segura es que Dado el kit tan avanzado de herramientas que tenemos a la mano, no debemos conformarnos con las tasas de muerte y enfermedad tan altas que afectan de manera muy avanzada a los más vulnerables. Tenemos que seguir cuidando a estas personas, ¿verdad? Cuidándonos unos a los otros, dado que las tasas de transmisión altas nutren el aumento en los riesgos. Se deben usar estas protecciones y precauciones de seguridad. Anticipándonos a la necesidad de volver al uso universal de mascarillas, hemos comenzado a comunicarnos con nuestros grupos comunitarios y seguiremos organizando varias juntas informativas para diferentes sectores. También estamos actualizando nuestras guías y estamos preparando materiales en varios idiomas que brindan información más detallada sobre los requisitos relacionados con el uso de mascarillas en interiores. Puede haber mascarillas gratuitas disponibles para empresas pequeñas y para organizaciones comunitarias, comunicándose con ppeunite.org. Lo voy a deletrear. Es ppeunite.org. De nuevo, ppeunite.org. Next slide, please. Actually, no, we're done with slides. Ya no tenemos más gráficas para compartir. Ahora lo que vamos a hacer es que vamos a cerrar, pero antes de que cierre, tengo una actualización bien rapidita sobre Novavax. Les quiero compartir que la FDA otorgó una autorización del uso de emergencia para la vacuna Novavax. El Comité de Vacunas de los CDC, este comité que se llama ACIP por sus siglas en inglés, se va a reunir el 19 de julio para analizar las recomendaciones clínicas. Según el New York Times, el gobierno federal comprará 3.2 millones de inyecciones y más dosis serán dadas a los estados a donde hay más adultos que no están vacunados. Su uso fue aprobado para adultos mayores de 18 años y es una categoría como la serie de vacuna primaria o vacuna inicial, no como refuerzo. Es una vacuna de 2 inyecciones con las dosis administradas 3 semanas entre sí. Como recordatorio, Novavax se creó utilizando una tecnología de proteína recombinante que se ha utilizado antes en otras vacunas como la de la hepatitis B. Les brindaremos más informes a medida de que haya más información disponible sobre cuándo podamos esperar que la dosis esté disponible en nuestro condado, aquí en Los Ángeles. Gracias. Para cerrar, les quiero dar las gracias a todos por hacer su parte para protegerse a sí mismos y a los demás. Gracias por usar su mascarilla, por quedarse en casa cuando esté enfermo y por hacerse la prueba. Su cuidado y su consideración hacen la diferencia y ayudan a proteger a toda nuestra comunidad de los impactos de esta pandemia. Que tengan muy bonita tarde y hasta pronto.
That concludes our Spanish portion. Thank you for attending. If you still have follow-up questions, please email them to media@ph.lacounty.gov.